Hello, Dr. Green. My name is Young. I am an RT student from Malcolm X College. Mr. Orange has severe COPD and he suddenly became tachycardic, hypotension, and hypoxemic. When I listened to his lungs, I noticed absent breath sounds on the left side and loud wheezing on the right side. When I palpated, I noticed crepitus, which means he is developing subcutaneous emphysema, and noticed JVD. On his current vent setting, AC, VC, rate 18, tidal volume 550, 40% FiO2, PEEP of 5. His ABGs were PCO2 68, pH is 7.27, PO2 45, bicarb 32, and SaO2 79, and hemoglobin 13, which is acute on chronic respiratory acidosis with moderate hypoxemia.
Okay, well, what do you think is going on with this patient? I've been receiving calls about auto PEEP, but I did not order that.
I believe this patient's lung ruptured due to the high auto PEEP of 10, possibly a tension pneumothorax due to the absent breath sounds on the left side of the lung and a loud wheezing on the right side. Also, auto PEEP is not something you can order. It is an indication of air trapping, which you can see on the vent monitor. As you can see here on the flow waveform, the patient is not returning to baseline, and over time, that leads to buildup of air trapping, which can rupture the lung and lead to a pneumothorax.
Okay, so what steps do you recommend, and how can we prevent this in the future?
Right now, I recommend a needle decompression and a chest x-ray stat. The needle decompression will release the built-up pressure and will improve patient SpO2 and blood pressure, then increase peak flow.
Wait, why do we need to increase peak flow?
Increasing peak flow will increase E time so that patient can exhale to baseline and prevent air trapping. As you can see now that I have increased the peak flow, E time increase and patient exhale to baseline.
Okay, and what lung characteristics makes the patient need such a long E time?
As you can see the chest x-ray, the patient lung is hyperinflated and they have a flat hemodiaphragm, which means they need more time to exhale and they are taking in more lung volume, which is a characteristic of COPD patients.
Okay, that makes sense. So auto PEEP is not a mode or an order. Auto PEEP tells us if a patient is air trapping. So a longer E time will allow patient to exhale fully and prevent auto PEEP. Is that right?
Yes, that is correct.
All right, so I'll put in the order for needle decompression and stat chest x-ray.
As you can see here, this is a tension pneumothorax. There are no lung markings. The lung has collapsed and the trach has shifted to the right.
Okay, patient vitals are looking good, but I still hear wheezing in both lungs.
Well, I recommend giving the patient a dual neb treatment to open up the airways, and that will stop wheezing.
But why not just albuterol? That also opens up the lung airways.
Well, dual neb contains albuterol and Atrovent. Atrovent is SAMA, a short-acting muscarinic antagonist drug, which will help prevent future bronchospasm.
Okay, that makes sense. It sounds like the patient will benefit from the dual neb more than just albuterol. Okay, we'll go ahead and give that dual neb treatment. I'll put in the order, and I have another patient to go see, so let me know if the patient does not respond well to the treatment, okay?
Okay, thank you.
All right.